Organizing for healthcare justice in the age of austerity and the Affordable Care Act. I'm Martha Livingston. I work with Physicians for a National Health Program, mostly with the Metro New York chapter. I also, full disclosure, am a professor at SUNY College in Old Westbury, where I teach public health. And what we're going to do today is just what that title says. Look at the first word, organizing. We're going to talk about where we are. Hey, Sid. I don't know how many of you were at the earlier session, which was maybe a little more broadly, I don't want to say theoretical. It wasn't that it was theoretical, but it wasn't as action-oriented and as here's what we're doing right now oriented as this session will be. So, because we're at a conference called the Left Forum, I want to situate us within a left political context. And just a point of personal, it's not personal privilege, it's personal indulgence or self-indulgence, that I've been involved in this movement since about 1992. And I've been saying the whole time that the movement for single-payer health care is actually a modest, nay, tepid reform. That is to say, people say to us often, oh, yes, our ultimate goal is single-payer, but, and then they'll come to some sort of intermediate point like, let's fall slavishly behind Obamacare for the meantime, because that's the going thing. But in point of fact, single-payer is a modest reform in the sense that it does absolutely nothing to alter the relations between healthcare professionals, healthcare workers, and people who need healthcare. It does nothing to alter the way healthcare is structured. All it does, the one little wee thing that it does, is to take payment for care out of the hands of the for-profit insurance industry. So as such, it's really quite a modest step along the way to healthcare, true health and healthcare justice. So what I've been whining about since '92 is I've said, and let's see if anybody will go for this. Raise your hand if you think this is a great idea. Let's chain ourselves to the White House gates demanding socialized medicine, because then everybody would see that single payer is really the centrist alternative, you see. But we've never done that. We've always negotiated with ourselves before we even get to the table. We saw that play out, especially for us painfully during the whole sausage-making process that resulted in the Patient Protection Affordable Care Act, PPACA, now called the Affordable Care Act or Obamacare. And we are now living with the consequences of that program. Come on in, come get a seat. And it's been especially politically tricky for us. Come on in. Feel free. I know, we need a door over there, right? So people can, but there isn't one.
Take over the arena 2 doors up.
So it is not an acceptable political position to say, which is basically what we were told for a little while along the way, shut up, sit down, and wait and watch the Affordable Care Act roll out, because then when it collapses under its own weight, which is, we think, ultimately inevitable, then you're allowed to leap in, say, I told you so, and take over again. Well, that's no way to build a movement. That's a ridiculous way to build a movement. On the other hand, it's very tricky because we have to be careful how we say what we say, lest we be allied with the troglodyte right. And so we were for a little while kind of in a box. But we don't do well doing that to ourselves. So we're out of any boxes we might temporarily have been thrust in. And we've been organizing a lot, even as the Affordable Care Act rolls out. we've been organizing. And this panel is going to be about the kinds of organizing that we're engaged in, much of which is state by state, but also constituency by constituency. And our mission here is not just to talk to you, of course. It's not, it's not to understand the world, it's to change it. I know that in certain broad ways we're preaching to the choir, but we feel as though some of the folks in the room are not people who are engaged in this particular wing of our overall movement. And so we welcome you and want to hear from you and want to engage you in the struggle. So most of what's been, can I have that for 1 second? Because I wanted to announce that. Most of what is now playing out, we have a national movement. You'll be hearing some about it. But a lot of what we're doing is now at the state level. And we have some great state-based activists in the room who are going to talk about what we're up to, in particular in Vermont and in New York. And I also want to encourage folks, when we organized our healthcare sessions for the Left Forum, we said, we're on a healthcare track, and we want as many of our sessions as possible to be right in the same room and certainly not to conflict with each other. There's a great session that's going to be right after ours at 5:30, and it's called The Domino Effect, Growing the Healthcare is a Human Right Movement, one state after another. So you can see that that's an obvious kind of through line, and as soon as I shut up and we shut up, we'll be moving to W604, which is just one flight up. Howard, Matt, come on in. There are seats. So we'll start out with a brief overview about the national bill's rollout with a special perspective from Ben Day, ta-da, bios. And Ben is now the Director of Organizing for HealthCare Now, but was previously the Executive Director of MassCare, the Massachusetts campaign for single-payer healthcare. And under his leadership, MassCare grew into a coalition of over 100 member organizations and 5 local chapters. And the point here is this: as everybody in this room surely knows, the Affordable Care Act, Obamacare, is really Romney Care writ large, though Romney, of course, tried really hard to pretend that it wasn't so.
And that's because he passed it, because Romney passed it.
Yeah,
Not because it was any good, it's because that he passed it.
we understand.
Okay?
So Ben's going to give us a brief national overview from the HealthCare Now perspective, then a brief sort of how the Massachusetts situation evolved into the Affordable Care Act situation.
Sure. Well, thanks for having me. How's everyone doing?
Could you stand, please?
Sure. I said, how are y'all doing? You doing all right? Well, I'm in a typical situation here where I'm sitting way too far to the left to sit at the table. The weather is good over here.
I need to move the table now.
No. So, it was interesting. What Martha didn't say was that I was hired by MassCare to run the Massachusetts Sinai organization 2 weeks after the Mass Health Reform was passed. So I started my career in the single-payer land sort of trying to build the single-payer movement in the wake of the health reform law. And then I was recently, about 4 months ago, hired as Director of Organizing for the National Single-Payer Advocacy HealthCare Now. And the first one was a bit of an accident. The second one was not, because I really wanted to learn from the positive things that we've done right in Massachusetts, and then learning from the mistakes that we had made in Massachusetts. It is a very challenging organizing environment in the implementation of a sort of incremental bill to build a movement for single-payer healthcare. So it can go either direction. I think as the Affordable Care Act is being implemented, it could either marginalize the single-payer movement, as every community group on the planet tries to make sure that implementation helps them instead of hurts them. and says, well, we don't have time for single payer, we've got to make sure that this gets done right. Or it could be an organizing opportunity, because there's going to be a lot of fights on the ground as implementation is rolled out. So this could help us or hurt us. It's really sort of in our hands to be smart strategically as we organize. So that's what I'm going to talk a little bit about. And I know we want to keep this brief, so I'm only going to talk about two things, two sort of lessons from Massachusetts that I think are important to bear in mind as we're organizing for single payer, especially starting in 2014 when the Affordable Care Act is really rolled out next. But before I do that, I want to say that HealthCare Now has a few things that we're planning later in the year that you all can plug into. I think there's going to be a sign-up sheet going around somewhere, so just sign it if you're interested in these. One is we're going to try we're aiming for August to put out a single-payer activist guide to the Affordable Care Act. And there's a million overviews of the Affordable Care Act. We're not going to duplicate them. We're only going to focus on organizing opportunities, things that are going to happen in the next couple of years that will allow the single-payer movement to get involved and to sort of grow and to make our case and to expand our movement. And then shortly after that, we're going to be trying to steal, many of you may know Labor Notes, the sort of dissident labor organization, and they have these very popular troublemaker schools. You've probably seen the t-shirts everywhere, the hats everywhere, which are sort of regional strategy, training, skill exchanges. We're going to try and steal their model and sort of have these regional trainings where local groups can come together, local activists can come together and plan out how are we going to respond to the Affordable Care Act, how are we going to grow as this thing is being rolled out. And we're going to call them Everybody Institutes. It's sort of a clever, everybody in is a slogan. So if you want to get involved in that, just make sure you sign in the sign-up sheet. And then in October, we're going to have our annual National Strategy Conference in Nashville. So I won't talk about myself anymore or our organization. But I think that at the beginning, as the Affordable Care Act is being implemented, if you remember at the very beginning of that fight, when Obama had like a series of regional meetings, like town hall meetings, the single payer movement was the strongest movement on the ground. We had these 1,000-person rallies at all of them. And then shortly after that, the Tea Party movement sort of took over and had their town hall rallies. And shortly after that, there was sort of a large HealthCare for America Now, this large sort of centrist organization was built for the public option. And I think we started off strong, but we were really taken by surprise. And we have to make sure that that doesn't happen in 2014. We have to really plan out well and not be surprised by the right having a strong grassroots movement or the center. So here are the two things. One of the lessons is about organizing, and one is about messaging. The organizing lesson, I think, is to engage in the implementation process. This may sound obvious, but I think there's frequently a temptation in the single-payer movement to get frustrated that so many people are fighting within the current healthcare system and spend so little time working on single-payer. And so we sort of, condescendingly say, well, if you were spending more time on single-payer and we could just win it, you wouldn't have to do all these fights within the current healthcare system. And then we alienate them and they never want to work with us again because nobody likes working with condescending assholes. But the other way is to engage in solidarity work, right? Where you're with them, where you're with community groups in their fights within the healthcare system. You bring your single-payer messaging with you. You invite them to message around single-payer as they're fighting within the healthcare system, which basically you have to do, whether you're a senior and you're fighting within the Medicare system, whether you're in the immigrant community and you're fighting within that healthcare system, which is very exclusory, safety nets, any setting, you have no choice but to fight within this healthcare system, and that's where most of the energy in the country goes. So the best single-payer organizing model is to go where people's fights are and bring single-payer there, as opposed to trying to drag people out of their fights and move them into single-payer organizing. This is going to be especially important when the Affordable Care Act is being implemented, because the Affordable Care Act is going to implement every single community in some way. It's going to affect reproductive health, it's going to affect Medicare, it's going to affect low-income communities, it's going to affect regionally differently. In the South, it's going to be different than in the North. So it's going to be when 2014 rolls around, every community group, every interest group is going to be working on this. And if we try to drag them out of their work, it's going to be frustrating and it's going to be disappointing, and that's how we're going to end up marginalizing ourselves. And I think that's just sort of a good organizing philosophy in general, is to take solidarity actions as a model for single-payer organizing. The second thing, and then I'll shut up, is just around messaging. And this was a lesson that we learned the hard way by sort of doing it wrong. And that is not to disregard or dismiss the gains that are going to come out of the Affordable Care Act. And this is very, very tempting. And we did this, I think, when Massachusetts health reform was first implemented. We were sort of like, this is a bad law, you know, using sort of sweeping languages, not really bothering to mention or to note the gains that come out of the law. And it turns out that the gain, and again, I think this lesson applies regardless of what you think about the Affordable Care Act. The single-payer movement in Massachusetts and everywhere is going to be divided between those who think the Affordable Care Act is a step forward and those who think it shouldn't have happened at all and that it's a step backwards. But regardless of which of those positions you take, we know that there's going to be parts of the Affordable Care Act that help some communities, and there's going to be parts of it that hurt some communities. There's going to be winners and losers, and it turns out that the gains from the Affordable Care Act were fought really hard for and continue to be fought for really hard by a lot of our natural allies. So this is very similar to the first lesson, which is that if you use sweeping dismissive language and don't acknowledge sort of the hard-fought victories, you are going to alienate a lot of your natural allies. And again, they'll look at us as condescending assholes and we'll end up marginalized. So this is just, I think they're actually very closely aligned to each other. One is the sort of organizing principle of solidarity, and one is a messaging principle of solidarity. And the other lesson, I think, around messaging related to that we learned was that there's this catch-22 created by the Democratic Party being fully aligned with the Affordable Care Act and sort of seeing its electoral future as hinged to the success or failure of this law, which is that it becomes very hard to say critical things about the law, even if they're totally true and accurate, because a lot of our natural allies worry about the future of the electoral future of the Democratic Party. And we made a lot of mistakes around this too. The best way we found out, and it took us about a year or two to sort of get this right, the best way to criticize the Affordable Care Act in the areas where it deserves criticism is to use real people's stories. So, for example, we spent a lot of time attacking how the law was affecting the safety net in Massachusetts, because it essentially gutted the financing for all of the hospitals and health centers that were servicing low-income communities and minority communities, which is something that's going to happen nationally. Nobody really talks about it as the law is being implemented, and nobody will try to talk about it afterwards. But when we talked about it at an abstract level, we got a lot of flack back from sort of Democrats who are saying, well, it's an election year, that may be accurate, but I wouldn't be focusing on that right now because you're really going to hurt their chances. What we learned was if you instead collect stories from real people who have been hurt by the cuts to the safety net, when we're instead of saying at an abstract level, this is happening, we say, this is Catherine, she's a type 2 diabetic. Before the law, she was in the safety net, she was uninsured. She actually paid nothing for her prescription drugs or for her care. After health reform, she was required to buy a health insurance plan. It was subsidized, but she had co-payments that were so high that it amounts to a fourth of her income. It's a real story, and you can't react to it in the same way as, you know, by telling Catherine's story, you're undermining the future of the Democratic Party. So really ground your criticisms in real-life experiences would be my other lesson. So I think that's it. I think the goal of both these lessons is we have to build sort of a winning single-payer coalition. You know, the potential single-payer allies are larger than the potential single-payer enemies. It's just we have a hard time getting all those potential allies who are hurt by the current healthcare system to work together or to commit to mobilizing around single-payer. But the worst thing you can do is to sort of lose them through alienation or through disregarding the real fights that they're taking on the ground. So thanks so much for having me, and I look forward to the other speakers.
That's great. Thanks, Ben. Our next speaker is Mark Dudzic. Mark is the Executive Director of the Labor Campaign for Single-Payer HealthCare, which is a national organization he'll tell you a little more about. I'm pleased to serve on the
Steering committee.
Is that what, I didn't remember what it was called, right. As a member of United University Professions. And there's at least one other member of Labor Campaign for Single Payer in the room. Before Mark was the national coordinator of Labor Campaign, He worked with oil, chemical, and atomic workers. He worked with Tony Mazzocchi very, very closely for many years. And he came out of originally in Rahway, New Jersey, Local 149 of oil, chemical, and atomic workers, and served as full-time president of his local union before moving on. Mark is a longtime activist and one of the Raucous Caucus Caucus, that is the folks who got arrested for demanding some single payer be at the table when Senator Baucus was holding those hearings a few years ago on the way to the Affordable Care Act. So let's welcome Mark.
It's great to see the energy in this room, and I see this everywhere I go. The healthcare debate is not over, and that was actually my biggest fear once the Affordable Care Act passed. Like Martha, I've been around for a while, and I saw what happened after the defeat of the Clinton healthcare reform proposals in the early 90s, and we wandered in the wilderness for 10 years, and I don't see that happening to the healthcare justice movement today, and I think that's really, really significant in a lot of ways. Well, the Labor Campaign for Single Payer does exactly what its name says it does. We're an advocate for healthcare, to make healthcare as a human right for every person in this country. We believe that the way to do that is through a single payer system. Somebody like Len could probably describe it a lot better than I can, so I'll leave it to them to do that if there's some questions about that. But I think that what's unique about where we see our niche in this fight is how we, how we view our organizing project. Now, Martha said that single payer is actually quite a modest reform, and she's right. It doesn't revolutionize the system in any kind of really radical way. However, it is a modest reform that requires almost an insurrectionary movement to achieve, because it's attacking the largest and most profitable industry in the history of capitalism, the American healthcare for-profit industry, which is a $2.7 or $2.8 trillion industry. I used to deal with Exxon Mobil and British Petroleum and Union Carbide when I was in the OCAW, and they're like mom and pop candy stores compared to this industry. So that's really why it's so hard to achieve healthcare reform in this country, is because we are attacking this vested corporate interest that's at the very center of the capitalist system in the U.S. And that's the challenge that we have as activists. And in order to do that, I believe, and the Labor campaign believes, that we have to conceive of this movement as an anti-corporate movement, and conceive of building the kind of forces from below that can build the kind of mass movement, grassroots-based movement that can take on this mass corporate power at the center of the healthcare system. And in that context, we believe that labor is central to that project, that labor has to be the leading force to win healthcare as a right in this country. That it's our responsibility as trade union members to move this national labor movement into a very leading position where it shifts resources and political organizational capacity into this fight. And that when labor does that, we will win this fight. Now, I really think that that's the fundamental takeaway from this. If you saw, or you may not have saw, but in California there was some incredible fights around some initiatives last election day. They defeated a kind of a right-to-worky kind of provision that was supposed to pass, and they passed by popular vote the first tax increase in California in a long time. And they did that because labor saw that as a survival issue, and they went out and they mobilized and they won that. And when labor sees healthcare as a human right, sees single payer as a survival issue, we're going to win it. So that's where we see our role. Now, two topics here are austerity and the Affordable Care Act. I would just say that, on the issue of austerity politics, we view the fight for single payer as part of the high road solution to the austerity crisis. there would be no federal budget deficit whatsoever if the U.S. spent per capita what any other industrialized country that treats healthcare as a human right spends per capita for healthcare. There would be no federal budget deficit whatever. So just wrap your mind around that idea. You have these people telling us that we got to take away people's food stamps, lay off federal employees, shut down post offices, cut people's Social Security to solve a federal budget deficit that could be solved by making healthcare as a human right for everybody in this country and taking on the healthcare for-profit industry. So we see ourselves as part of a central part of the anti-austerity movement, and we see our natural allies as all of those who fight to preserve what we call the social insurance model, the idea that, that part of what government does is provide some basic security to working class people. So that's the age of austerity issue and why it's so central to that fight. And then the Affordable Care Act, I think Ben really hit a lot of the high points on how to view that broadly. I think it's a very mixed bag. It creates a particular set of problems for unions that try to negotiate healthcare through the collective bargaining regime. It accelerates all of the pressures that were already there around trying to bargain for healthcare. It's an impossible situation. We maintain that you got to take healthcare off the bargaining table, and that will help rebuild the labor movement. And ACA, quite honestly, is going to help that along, although not in a good way. I mean, it accelerates the race to the bottom pressures, the push to constantly reduce healthcare coverage. It's going to particularly impact low-wage and part-time workers in ways that will more institutionalize those inferior employment relationships. It disrespects, this includes immigrant workers in a very mean-spirited way that was not necessary and actually violates the premises of public health policy. And then you have the assault on Taft-Hartley multi-employer funds. There's about 25 million Americans who get benefits through union-sponsored welfare funds that are, in the labor movement, they tend to be the gold standard of coverage for workers. And these plans are under unique and particular pressures under the Affordable Care Act. And we can maybe get into that later if people have specific questions. But they're really facing an existential crisis right now. The group of unions that have traditionally organized using union-sponsored funds have tended to be the more conservative unions around health policy and the labor movement. And this crisis that they're entering into right now is really kind of shaking things up in the labor movement. And it's polarizing things. On the one hand, you have unions like the Roofers Union, which just recently called for the repeal of Obamacare and a return to the status quo before Obamacare, which I would maintain. There's some people in the single-payer movement who would celebrate that position, but I would maintain, for some of the reasons Ben said, that this is it's a very reactionary position. It discredits the very idea of healthcare reform, and that creates disunity at a time when we need unity. On the other hand, you have groups, I was just in California, and the San Francisco Building Trades Council just passed a resolution to join the Campaign for Healthy California, which is a single-payer organizing group in California. So you have, real new organizing opportunities there, and I think that this is going to really be an opportunity to move sections of the labor movement in ways that we've been unable to up to now. So I think there are some real organizing opportunities if we're smart and strategic and look at the Affordable Care Act as a transition from one healthcare system to another. I agree with Ben that we have to be very careful not to be self-righteous and condescending about the issue. There's a whole bunch of people in the labor movement who claim that they believe in the single-payer solution, but they felt that they had to support the ACA as a step in that direction. Well, now we need to challenge them to come take that next step, and that's really how you're going to organize your way into the future. So that I would just think this is a time where we really got to reorganize this movement, orient ourselves towards this broader anti-austerity movement that's come together in this country, and push labor to do more. Thank you.
Yeah, just add one point, Mark, and that is it's interesting that you didn't actually mention HR 676, which has been, to date, a really wonderful national organizing tool bringing labor on board. That's Congressman Conyers' single-payer bill. And he's very smart. At every new session, he waits until the number 676 comes up and then reintroduces his bill. And it's a great way to get unions and central labor councils and state feds and such on board, even if they do not much else besides sign on. It gives those of us in labor a platform from which to do organizing and speaking about this issue.
I think there's now 1,000 union organizations that have endorsed HR 676, so it's been an organizing tool for the last 10 years.
So, since we find ourselves at this moment really working more on the state-by-state level than nationally, we're focusing on 2 states in this panel, and the first speaker to do so is, I'm pleased to introduce my old friend Dr. Deb Richter, who's a former national president of Physicians for a National Health Program. She is now based in Montpelier, Vermont, and she's currently the president of Vermont HealthCare for All. And she's going to give us some information about what's going on in Vermont, which has really led the way nationally. I think people hear that Vermont has a single-payer system and that we can all just fall in line and do what they're doing. And in some ways we can, but Deb will tell you more about that.
Well, thank you. I appreciate being here. Yeah, the attitude we had in terms of organizing in Vermont actually started with the assumption that we aren't going to get national health care anytime soon, and that really this will eventually happen after several states enact a single-payer system to show the rest of the nation that you can cover everyone equally with a broad, comprehensive benefit package for less money than we're currently spending. So I actually moved to Vermont in 1999 to organize for a single payer because it seemed like a perfect state. And I found that when I got there, there had been a long history of organizing at the state level for single payer. In fact, in 1992, there was a massive organizing attempt, and the thought was that they were going to be able to pass it. That was actually when the national health care was being debated, and that went down in flames because it really wasn't the right time. In 2005, we actually passed a pretty good single-payer bill in the House and the Senate, but it was vetoed by our Republican governor at the time. Similar thing happening in California. So over the years, the state, we've had a pretty broad history of organizing for healthcare. And as states go, we already had a fairly good, compared to other states, but that isn't really a lot to brag about. I mean, if you compare us to Texas, where only 10% of Vermonters are uninsured, 25% of Texans are uninsured. But so we've had a much more progressive, most of our kids are covered under a Medicaid program, so we've had sort of a long history of that. But in 2011, all the stars were aligned, and by saying the stars, I'm meaning for at least 20 years, our Senator Bernie Sanders, who was a former rep, a former mayor of Burlington, et cetera, has always been running around the state talking about single payer. We're going to get single pay in Vermont. And so Bernie has been a massive force over the years, along with a lot of these other organizing groups and whatever, including labor, a business group called Vermont Business for Social Responsibility, our group Vermont HealthCare for All, the Vermont Workers Center has done a massive grassroots organizing, Vermont Citizens Campaign for Health. So we've had a bunch of groups over the years. We also had a study that I think by Dr. William Shao, who's a Harvard economist, who actually enacted a single-payer system in Taiwan. So he had really done the work, and they went from 45% uninsured to 5% uninsured within 1 year's time. So our governor actually brought, he was pro tem at the time, brought Dr. William Schau to do a study in Vermont to sort of outline how we could implement a single-payer system in Vermont. That was one of the other stars aligned. We also have had over the years a very progressive legislature who, again, they voted for a single-payer system in 2005, and we're really poised and ready when we had the right governor. And we finally ended up, we elected Governor Peter Shumlin, who actually campaigned on single payer, along with, in a primary where I believe 4 out of 5 of the candidates were arguing about who was a stronger single payer supporter. So I don't know if you can say that about New York State. Again, it has a different, I would say the word, it's not as much of a dirty word. And Governor Shumlin actually campaigned and did commercials. You can actually find them on YouTube for single payer. So we had all of these things in place, and in 2011 we passed Act 48, which essentially everyone keeps thinking, oh, we've got single payer in Vermont. Well, unfortunately, the Affordable Care Act it didn't allow us to do single payer right away. So here we were all poised and ready, we had all these things going for us, and then we had to hurry up and wait till 2017 and enact the pieces of the Affordable Care Act in the meantime, which in our case is really a waste of time and money and energy. And in some cases, it's a good thing, in some cases it's bad. We already insure people up to 150% of poverty under our Medicaid program, and kids up to 300% of poverty. A lot of those people are going to lose out under the Affordable Care Act. So in the exchange, they're going to end up paying more money. And I actually mostly do primary care and addiction medicine right now. Many of my patients are in this program, this expanded Medicaid, and I'm very worried that we're going to have a lot of people relapsing because they're not going to be able to afford. So we actually are now in this balancing act of trying, where the exchange is going to start in October, where we're going to start marketing. And my concern is that because the impression is that single payer has already been passed, and people are going to confuse this exchange with single payer. So we really clearly have to get organizing to let people know it is what it is, folks. We have to do this, but it is not single payer, and this is exactly why we need single payer. We actually have the best of circumstances in Vermont, and it still isn't covering everyone. There are still many people suffering, still many people going without. And so that's going to be our big problem. And so in Act 48, our roadmap, though, the eventual thing, and the administration is still talking about, we want to do single payer in 2017. So we have the roadmap, but we have to follow the roadmap. We can't, and there's many, many ways that we could go off the road, essentially. There's going to be many, many opportunities for mischief. The opposition has much more money than we do. But we have an advantage in that we're a small state with only 300,000 voters. There is already strong grassroots energy. The Vermont Workers Center is one. We have, again, Vermont Business for Social Responsibility, Vermont HealthCare for All, Vermont PNHP. There's a lot of organizing already there with Bernie Sanders. So the advantage in our state is that because we're small, we actually can overcome the money interests. But again, it's going to be a long road. That's sort of just a general summary. Did I do that in 7 minutes?
I'm hoping during the Q&A that people will get to really engage with how that plays out in the real world.
Yes.
Because Deb made it sound as though it was maybe a little bit challenging, but it's way challenging. It's way challenging. So what we're going to be doing for the balance of the speakers' presentations is talking about New York State. And first we're going to have Len Rodberg, who's going to talk to us about New York Health, which is the bill that's before us in New York. So how many people in the room from New York? Okay, so I don't think so.
I was born in New York.
So
But
I
you
think
move
that
out.
I think it's useful for us to spend a little time talking about where we are on the ground in New York and what the next moves are because so many folks in the room are from New York. I ask because Left Forum is a national conference, and people, sometimes you'll be in a room and you'll say how many people from New York, and 3 hands will go up, but that's not the case here. So let me just introduce Len briefly, because one could introduce Len at length, but I won't. But Len is professor and chair of urban studies at Queens College, and along with his late wife, Dr. Joanne Lukumnik, he was one of the founders of Physicians for a National Health Program. And he's been involved in the struggle for healthcare reform since 1974, when he led the development of the Dellums Health Service Act. Anybody in the room remember Dellums? Yes. So there are, when I first came into this movement, I met a number of folks who wouldn't become involved with the single payer movement because it didn't go far enough. And so the Dellums bill was the National Health Service Act, right? And then Kennedy came in with single payer as the right-wing opposition. Anyway, whatever, that was then, this is now. We wish we were having that conversation nationally. Len is the treasurer and research director of the New York Metro chapter of Physicians for a National Health Program. And he also created and directs InfoShare, which is a community data website that if people are interested in, you can find that website in his bio in the program. So without further ado, Len Rodberg. Do people have these?
No.
Let me pass these out. There's not that many, but you'll share, I know.
Those of us in PNHP usually come loaded with a slideshow, but since there were so many of us on the panel and I didn't want to bring a lot of technology, I'm giving you the slideshow in paper instead. So I won't actually go through it very much. You can read it at your leisure. I want to make a couple of key points. Since as Martha said, this is a left forum, I want to say something about the economics here, and I'm afraid I'll disagree a little bit with my colleague to my left, literally. So first of all, the Affordable Care Act will fail. That is, it will not provide universal health care, and it will not control costs. That was its stated objective at the beginning. That was Obama's stated objective when he ran for office. He also, of course, promised us a public option, which he didn't give us. The estimate is, and one of the second slide that I show here says there will still be nearly 2 million people in New York State without any insurance of any kind. Even though New York is among the most generous states in its Medicaid program and covers undocumented, covers all immigrants if their income reaches the right level, is below the right level. The costs will continue to rise. Even the advocates admit that. But the Affordable Care Act has done 2 negative things, among many. One is it has legitimized high copays, and I want to come back to that. Or the way it puts it, it's legitimized these so-called metal brackets that are in the exchange process. They're the third slide on here. That is the typical employer plan covers about 87% of the average person's medical costs. The typical plan here, the standard default plan, covers only 70%. But even more than that, it's the conservative economist view that we need to keep people from using too much health care has been put into the law in the form of what is usually referred to as the Cadillac Plan Tax, the tax that Mark Dudzic and the union people know well about. That is, says that in 2018, a union, particularly union plan, but any employer plan that provides too much coverage is going to get taxed at a 40% rate. That is, the objective is to eliminate full coverage. There's even a very serious move today that really has to be resisted, and as far as I know, single-payer advocates have not been involved in this, to eliminate the possibility that people on Medicare can get first dollar coverage through their Medigap plans. I'll come back to that in a minute, because I think to me, that's a key point. So, as Martha and others have said, we've been advocating for now 10 years, the Conyers single-payer bill, tax-funded, the core of it. We have to find better language as advocates for universal health care. We use single-payer, and of course that term doesn't mean much to people outside of this room. But tax-funded, and the key that I'm going to come back to a couple of times is no co-pays and deductibles are allowed under the Conyers bill or the Gottfried bill, which is the New York State version of that. The Gottfried bill is described on the back of the sheet. I won't go through it. It is basically the Conyers bill for New York State. It has an innovation in terms of universal coordination of care being embodied in it. And because it's a state level plan, and like Vermont's plan has to take a lot of the money that the federal government is now spending and use it in order to make its plan affordable, workable, it needs the waiver to allow state to take that federal money and incorporate it into a state plan. But again, I want to come back to this idea that there's no cost sharing in the plans that we have, because I think to me there is a fundamental change in that we're talking about when we're talking about the national health program, because we're talking about transforming healthcare from being a commodity that people have to purchase, first by buying insurance and then by making the payments at the time they receive care, to transform it from a commodity into a service that's publicly funded. That is, it's funded through the tax system, and there's no cost sharing. That's the way it is. If you go to Canada or go to most other countries, advanced countries in this world, people do not have to pay money to get health care. They still do in this country. They still do under the Affordable Care Act. They will not have to under this act if we keep our eye on that provision, and we have intended to. We need to find language. My view is we need to find language which puts that aspect front and center, along with the tax funding, the single payer aspect, the fact that there is no financial barrier to getting care under the kind of single payer plan that we're advocating, whether it's the national Conyers HR 676 or the New York State Gottfried-Perkins bill, which is described on here. Vermont, the Vermont board that is designing the plan at the moment is still talking about involving cost sharing, and that to me has to be a central struggle that the people in Vermont are going to have to wage. That if you want to make this transformation from a commodity to a service, you have to see healthcare as a service and not as a commodity to be bought. Thank you.
Conversation about New York State. It's my pleasure to introduce Okah, who's a first-year medical student at Mount Sinai School of Medicine and the co-president of Mount Sinai's Student Chapter of Physicians for a National Health Program. Before attending Mount Sinai, she was a volunteer with HealthCare Now in New York City, and so therefore she comes with a wealth of passion and experience on the single-payer front. And Avi's going to talk to us about the work on building for New York Health, the Gottfried-Perkins single-payer bill in New York State.
Hi, she mentioned I'm Amy, and I'm one of the co-presidents at Mount Sinai School of Medicine, the PNHP, and I'm going to talk to you a bit about some of the activities that we've had this past year and some of the challenges that we're dealing with as we sort of trying to build a coalition within the student body. One of our successes, or one of the things that I guess I'm most excited about, is that we got our Assemblyman Robert Rodriguez to sign on to the New York Health Bill. When I initially took on this position, Maybe he was on the fence, I'm not quite sure exactly where he stands once we hadn't signed on. And we had decided to set up a meeting with him in the spring with other PNHP students to encourage him to sign on to the bill. And eventually he signed on. The next stage was to sort of build support for the bill. We decided that we wanted to set up a town hall in his district to, I guess, let his constituents know the work that he's been doing on healthcare, and to also educate people as to what single payer was. It was a small group, but it was very exciting to be able to speak to people in the community, and people seemed very enthusiastic. So that's something that I'm very proud of. We also, I, along with the other co-president, went to Laurie Day, so I'm going to talk briefly about my experience there. I hadn't done that before, and we rode up with a bunch of other Cornell students. There were like a ton of Einstein students who showed up. So that inspired me. I guess it has me thinking about ways in which to sort of expand the PNHP Sinai community. I had a great time. I spoke to representatives and tried to get them. And the interesting thing was, people seemed very receptive, to the idea of signing on to the bill. When we got there, they're like, oh, this is something we'd be interested in doing, so we'll see how that turns out. But for me personally, I'm hoping to grow the Sinai chapter so that it can be, there are 11 Einstein students. So this sort of gets to the challenges that I see that we'll be facing this year as we try to build the Sinai PNHP chapter. For one thing I realized when I first took on this position is, I guess, you come in with the assumption that everyone, I guess, is not necessarily has your knowledge, but people, I guess, tend to assume that people have their point of view in general, right? And one of the major challenges that we've had is educating students to what single payer is. Surprisingly, not a lot of students know what single payer is. Secondly, feasibility. So I think what the difference is in terms of getting younger people engaged in this sort of movement is that they may not have had a lot of experience with the healthcare system. So sometimes what motivates and inspires you is the struggles that you've had, and you can say, okay, well, I went to the doctor, but I couldn't get this service because my health insurance company didn't cover it, or the variability in coverage based on the quality of your health insurance. And for students who are currently on their parents' health insurance or are just coming right from college, there's this sort of challenge because they haven't really seen how fragmented the system is. Some of the students, so we have a student clinic, as most medical schools do, and I feel that some of the students who are involved in the clinic, and I've seen how difficult it is to access care for patients who are low income and don't have health insurance, have a sense of how single payer can be beneficial, but because it seems like such a far out idea, it is sometimes challenging to get people to show up and show support. So I think the two things that we will be working on in the upcoming years is working on educating other students on what single payer is, and making it something, or at least the New York Health Bill, the passage of it, something that seems a bit more feasible.
I just want to insert a quick anecdote here based on what Abby said, and then it sort of feeds off of what Ben was talking about you really, human stories about individuals are really what brings people in. You can tell them all the stats in the world, but you can't argue with this is so-and-so, who couldn't get the care they needed. Quick anecdote, I promise. So I'm doing a guest lecture at Queen's University in Ontario. How am I doing this lecture? By iChat from my office in Old Westbury, New York. And I happened to have my seniors that I was meeting with who were doing research, and I said, and I'm blah, 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 talking to the Canadian students, yada, yada, Dr. Livingston, blah, blah, blah. And I just randomly, I said to my students, come on in, come talk to some Canadian students. Random, I had no idea what their experience was with U.S. healthcare. 6 students came up, hi, my name is Joe Schmo, and blah, blah, blah. And, you can see each other, right? You can see the 80 students in the lecture hall in Ontario. 2 out of my 6 students told stories about how they each were $20,000 in debt from some healthcare experience that they had had. And 80 Canadian students' jaws dropped as one. They couldn't imagine, these are people who look like them, right? And they could not imagine how a 20-year-old could possibly be $20,000 in debt because they had a car crash and needed some medical care. It was beyond their imagination. So those kinds of stories are really important, and young people often don't have that direct experience. Okay, I didn't mean to steal time from Laurie, so I won't. So we're going to wrap up our presenting and then get into the back and forth. Laurie Wen is the executive director of our Metro New York Metro New York chapter of Physicians for a National Health Program. Please don't report me to national. I just totally screwed that up. She got involved in health justice through working with ACT UP, and is also a steering committee member of HealthCare Now, and has been working since the fall of 2011 with HealthCare for the 99%, an official working group of Occupy Wall Street. So Laurie is going to talk more about what we're up to in New York State, and then we'll go back and forth and around.
If you're still having any doubts about why so many of us are spending so much of our time working on state-based single-payer campaigns, if you're probably not having any doubts, but if you are, I'm going to share a story with you. So a few months ago, I went to see a doctor. She was a new doctor for me. She was suggesting a medication and made an offhand comment about that pharmaceutical company, and then the pharmaceutical industry, and then the nefarious effects of corporate interest on the practice of medicine. She was upset. Offhand comment, but still. I had a big grin on my face, and I said, wait till you find out what I do for a living. What do you do for a living? I work with a doctors group called Physicians for a National Health Program. She looked at me and she said, I love you. And then she said, I have a confession. I used to be a member. 12, 15 years ago. I stopped being a member and kind of, lapsed on membership dues because I lost hope. I just didn't see how it was going to happen. Especially now, the last few years, with the passage of the Affordable Care Act. I mean, I applaud you for working on it, but I just got too frustrated. I understand. It's frustrating. It's frustrating when we don't see the amount of progress we want. But by any chance, are you familiar with the campaign to get single payer in New York State? She said, no, I didn't know about that. Tell me about it. The whole conversation changed, and the whole energy of the room changed. And we talked about the state campaign. And she finally saw a sense. She got a sense of the possible. And so I think as organizers, for any movement, on any cause, if you cannot impart a sense of the possible, you're going nowhere.
Exactly.
And the person who's responsible for the Affordable Care Act, President Obama himself, conventional wisdom said that he had no chance to win the presidency. He was a junior senator. He was going against the most famous political name of the last 50 years, Clinton. He was an African-American man. There were all these lies about him. he excelled at giving a sense of the possible. And he mobilized a lot of people who then gave more of a sense of the possible, and he won. So for me, in addition to the very real possibility of getting everybody in Vermont healthcare, universal, affordable, and high quality, of getting everybody in New York State, everybody in California, everybody in Kentucky, in addition to that very real possibility of actual healthcare, actual single-payer systems, 1 state, 2 states, 3 states, is also about imparting that sense of the possible to the rest of the country, without which we will never reach national single-payer. So I'm going to get back later to using that as a central part of an organizing platform. But right now I just want to zoom back out and talk a little bit about the history of states, very briefly, about the history of states and provinces leading the way. I mean, it's really obvious, but I just want to touch on it. Many of you probably know that in Canada, it started in the province, it started in Saskatchewan. And the guy who did it, the architect of Medicare, I'm sure a bunch of people know who that is. Who was that? Tommy Douglas. Tommy Douglas, decades after his death, was voted by 1 million Canadians as the greatest Canadian of all time, beating Wayne Gretzky and everyone else. So, in Canada, it started on the province level. In our country, there are endless examples. Women's suffrage. People know where that actually first became? Yes, right. People in that region should be very, very proud of that. It started in Wyoming. It took a few decades until 1920 before it became national. Right? But it started on the state level. The most potent and exciting example happening right now, obviously, is marriage equality. Although I have to add a note about, I know many gay rights activists who are a bit disturbed that the two fronts of the mainstream gay rights movement are about fighting for the right to get married and fighting for the right to fight in the military. But that point aside, this is really about, a sense of the possible and how that moves your social movement. 5 years ago, did any of you, or really anyone else in this country, could you have predicted that at this point we will have 12 states that have marriage equality? I mean, I think it's astounding. It's absolutely astounding.
I thought I was going to be dead.
So, and you can be damn sure that that has major impact on when we're going to get marriage equality nationally, right? The people who made marriage equality happen in Iowa, they didn't say, well, we only care about Iowans. Like, we don't care if people in New York can get married. We don't care if people in Mississippi. They didn't say that. They said, we know what we are doing here has an impact nationally, and this is go around the country. So that's exactly every single person I know who is working hard on state-based single-payer campaigns. We want national to happen. We're not doing this because we only want New Yorkers to have it. We want people in Arkansas to have it. But this, many of us think, is clearly the most viable way to get there. I'm going to quote James Haslam, who is the executive director of the Vermont Workers Center, and Dr. Richter has already mentioned what a prominent major role that his organization has played in the major progress and victories in Vermont. I remember asking him, James, what should we do to help your fight in Vermont? I mean, really, honestly, like, we know that what is going to happen in Vermont is going to have major impact on the rest of the country. What do we really need to do? What do you think he said?
His answer was, leave him alone. And that's what happened in Vermont. It almost happened.
He said, fight in New York. Your fight in New York is absolutely going to strengthen our fight in Vermont, which is absolutely going to strengthen the whole national fight. We don't want to be an outlier, and we're not an outlier. And let's make that very clear to everybody. Okay, so I quote you all over the place. The Ohioans loved it when I did that. So, and it's obvious why that works on the psychological level. To people who are not convinced it reduces fear of the unknown. Now, of course, those of us who are working in this movement, it's not unknown. We have had Medicare for many years. It's not a perfect system. We need to improve it. But we're just saying improve an existing system and expand it. It's not actually unknown, but obviously, as in everything else in life, facts are not the only thing that matter. Perceptions matter a lot. And if you are pushing a movement forward, you cannot ignore people's perceptions, right? So there is a perception of fear. So it helps reduce that fear when other states are doing it. It's not this unknown foreign thing. There's on a psychological level. And then, of course, in terms of data, again, we actually have tons and tons of data, both from Medicare, the efficiency of Medicare, and from dozens and dozens of other countries in the world. Decades and decades of data. But again, we're talking about people for whom that's, for some reason, not working. And we need to look at that. We can't just keep saying, this makes sense to me, and if it doesn't make sense to you, I'm not talking to you. Well, figure out what makes sense to them, right? So it can be seen as a pilot project. The data, hopefully coming out of Vermont, once we get a voucher from the federal government in 2017, that data is going to be helpful in convincing certain groups that this is a completely sensible and moral thing to do. So now I'm going to move into talking about 3 categories of people for whom this is a fantastic organizing platform. Pretty obvious in any campaign. You have targets, you have constituents, and you have allies. And for all 3 state-based single-payer campaigns, I have certainly found to be extremely useful in starting a conversation and in moving it forward. Because you can't start a conversation, you can do anything.
And opponents, you have opponents.
So targets, obviously, they're the folks who have the power to satisfy your demand, and in this case, they're state legislators. What are the 3 most common tasks that state legislators take after they leave Albany? What was that?
Oh, governor.
I'm sorry?
You should try for governor.
Oh, governor, okay, moving on to the governorship, okay. Congress, exactly, Washington. The 3rd one, unfortunately, is prison.
Don't get out of my mouth with an indictment.
Yeah, so in the last 6 weeks alone, maybe 7 weeks, we've lost 2 co-sponsors to that. But yes, Congress, Washington, D.C., that is a very common path for state legislators from many states, certainly from New York. 50% of U.S. senators and U.S. congressional representatives are former state legislators. And of course, the most famous former state legislator right now is Barack Obama, who was a state senator. Senator Schumer, one of the most powerful people in our country, he's a former state senator, right? So many of them, there's a pipeline that goes from Albany and other state capitals to Congress, sometimes to the White House. This is a time when it's much easier for you to reach them. It's still not the easiest thing, but they have less power. They have smaller districts. It's much easier for you to show a petition with more names on it than the margin with which they won their district. And because the districts are smaller, the races are usually more competitive, you have a much stronger environment to organize it and to reach out to them and to educate them. I do want to say, of course, we're not naive about this. Just because people are educated, and even if they agree with you on a policy level, doesn't mean that politically it's going to happen. Obama understands single payer and has publicly said that he knows that's the only way to have universal and affordable health care. He knows it. He's actually a former patient of PNHP's national founder, Dr. Quinton Young in Chicago. And he gets it, right? So it's politics. We have an $800 billion industry of fighting against. So we're not saying, oh, while they're just in Albany instead of Washington, when we get through to them, they're educated, then we're all good. We're not saying that. But it's a very, very important first step. And we can reach them now and build a relationship with them, educate them, and it is an important foundation to build. That has happened with a number of state legislators from New York who are now in Congress. We got them when it was a little easier. Secondly, allies. we're absolutely not going to win this fight without allies, without groups whose sole mission is not single payer. There are very, very few organizations whose only mission is single payer. Physicians for National Health Program is one, HealthCare Now is another one, Labor Campaign for Single Payer Healthcare is another one. But we don't have the resources that many of certainly that our opposition has, and a lot of our allies. So what working on a state campaign has certainly shown me personally, and shown our chapter, is the fantastic opportunity to reach out to them and say, I know you worked very hard to help pass the Affordable Care Act. I know we may disagree on how the Affordable Care Act is going to affect us, but I also know that you ultimately want single payer. Let's find common ground. And hey, the state single payer bill is common ground. I have had that experience over and over again with allied groups. And because we are a physicians group, we first, of course, go to other physicians groups. Do people know about Doctors for America? They started out life as Doctors for Obama. It was a campaign organization. They were supporting Obama, the candidate. So you can imagine that when they then transition into Doctors for America, that they spend a lot of time and energy and resources fighting for the passage of the Affordable Care Act, and they did. So we may disagree on whether we're going to put energy supporting the Affordable Care Act, and in fact we're not. However, New York State Doctors for America has endorsed the New York State Single Payer Bill because we've been working with them and collaborating with them. We understand what we may disagree on, and we look at what we do agree on, which is single payer. And there is a perception among many allied groups that we cannot support national single payer while the Affordable Care Act is being implemented. Now, again, we can disagree on that. You can't necessarily change their minds on that, but you find what you can work on together. And time again, we have found that they will work on state single payer together because they will allow themselves to think that that is not in contradiction with the Affordable Care Act. It's okay, we can move forward on the state level. And nationally, okay, we're also going to work on that. So Doctors for America, that's been true. National Physicians Alliance, that's been true. Many groups, we have found this to be a great platform and great common ground to work on. And then lastly, constituents. This is going back to my new doctor. That was not an isolated incident. In the last year, and especially the last few months, I have heard so many people tell me that. Something to the effect of, I thought it was pie in the sky, but when you told me you only needed 2 more co-sponsors in the assembly to pass the bill, I suddenly realized it was possible. I have had so many people tell me that. A lot of our own members who at some point were a bit discouraged because nationally we've been facing so many challenges. So, on a more concrete level, what did this sense of hope, right? So I keep saying, well, it allows us to have a conversation. It allows us to give people a sense of hope. What does it actually translate into, right? Is this abstraction, sense of hope? It has translated into the most progress we have seen in 20 years in New York State. As of last week, we have more co-sponsors than needed to pass the New York State single payer bill in the assembly. We went from 60 to 77. This is the kind of stuff that my husband always tells me, this is actually really boring to normal people who are not obsessed with state politics like you are. But I'm going to try anyway. Okay, so there are 150 assembly members in New York State, and you only need a pure majority to pass, so you need 76. Right? So when we started in January this year, before the bill was introduced, and we worked very closely with the bill sponsor, Assemblyman Godfrey, chair of the Health Committee, we had 60. We had 68 during the last session. We lost 8 of them to either defeat in elections, or they retired, or they went to Washington, whatever. So we started with 60. And we pushed and we pushed. We wanted more co-sponsors before it was officially introduced. So between January and now, we got 17 more. Actually, we got 19 more, and we lost 2 to corruption and scandals and resignation and possible imprisonment. But we worked hard. A lot of people in this room have worked very hard on this. Josh Starcher from HealthCare New York City has done so much for this campaign. So that's a lot of legislators to convince. Right? We got really 19 more from just January. In the state Senate, we need 32 to pass. It's much smaller. 63 of them, we just need 32 to pass. 3 years ago, when most of us were really focused on the national level and not really pushing on the state level, guess how many co-sponsors we have in the Senate? A big fat zero. Now we have 18, and we need 32 to pass. So we've made a huge amount of progress. And that is the concrete progress that came out of the sense of hope that I was starting this whole conversation with. So right now, the legislative session of this year is about to end. We still have to convince Speaker Shelley Silver to bring the bill to the floor to vote, right? So we have to vote. He's stalling. So in a minute, I'm going to say something about that. But actually, no, I'm going to say that right now. Yeah. So what we really, really need you to do is a few things. Very simple. They're all very simple. One is the clipboard that's passing around. If you're not already on our list being the PNHP New York Metro Chapter email list, please sign it. Who has the clipboard? Please. Okay. If you'd like to get updates, find out what's going on, get involved, please sign. And secondly, as I mentioned, we have enough co-sponsors to pass the bill. In the assembly, But we need Shelley Silver, the speaker, it's not a very democratic system. One guy gets to decide whether we even get a vote, right? So we need you to call him. And his number is, if you could please pull out your cell phone. Right now. Right now. I don't see you doing it. Okay, thank you. All right, pull out your cell phone right now. Yes, please. It takes no time. So 518, his number. And if you really can call now, write it down. But I guess everybody can call at the same time. But okay. Write it down. But at least a few of you should be calling. Okay, right now. 518-455-3791. Again, 518-455-3791.
That's Shelley Silver.
That is Shelley Silver, the Speaker of the Assembly. He is holding the fate of the single-payer bill in the Assembly. He's our big enemy right now. Call him, leave a voicemail. Obviously it's Saturday, nobody's going to answer. This is an Albany office. Leave a voicemail, you can make it brief. I urge you to bring the New York Health Bill for a vote. The bill number, if you want to grab this, the bill number is A5389.
A5389.
Yep, A5389. I urge you to bring this bill to the floor for a vote. It has enough co-sponsors, and your constituents want this to happen. New Yorkers want this to happen. We want universal, affordable health care. Please do not be an obstacle to this major progress. Thank you. Please take the call. Okay. Thanks a lot.
Okay, discussion. Speak up, please. Can you speak up? We can't hear you.
I can't wait, so I don't know if we discuss this at all, but what's going to change what already happened here when they get this new health care
People who are already on Medicare, how is it going to change with Obamacare?
So it's not.
You're already on Medicare, you just make the same?
Yes. Yes.
The donut hole will get smaller over time.
The last session, the last forum, I asked about insurance companies and the doctors said that they were having a meeting following this session. I just wonder where it's at with insurance companies and they're not on board with this, I'm sure.
We're calling to destroy them, yes. We're calling for their disappearance.
Yeah, so are they they're pretty strong in Washington, so what?
More respect for the prosecutors.
We haven't yet confronted them here in New York State. We will.
Okay. Ann?
Yes, I just want to go back in time for a minute on our history. I was working.
Backward never.
Well, I think it's good to remember your history, and I'm forgetting one little piece here, but I'm remembering a lot of things. Wellstone McDermott, that was single payer, and I think it was 99. We had 99 people in the House. Only one senator, that was Wellstone. And then Hillary came in, and she had a bill. And we keep hearing from time to time about Hillary, that died, or was killed, or something. What happened to Wellstone? What was the shenanigans that got rid of that bill? Was it voted down, or anybody remember Wellstone?
Hillary killed that bill.
How did she?
We elected Clinton in 1992. He ran on the issue of healthcare. There was a period of crisis in the healthcare system, very similar to the sort of Obama experience. And then Wellstone McDermott was the primary bill. It was supported by the labor movement almost universally and by a number of other forces. Bill Clinton appointed Hillary Clinton to run a commission to come up with legislation. She wasted a year or a year and a half meeting with healthcare lobbyists, basically, and constructed a bill that, as I think Martha said, we always bargain against ourselves. It was tried to concede all of these things, hoping that they'd get buy-in, and split the labor movement right down the middle. The crucial vote was 5-4 to support this new Clinton bill versus the traditional support for the single payer, and the rest of the sort of social movements got split along those same lines. And then, surprise, surprise, the HealthCare profiteers turned on the Clinton reform once they had disabled the sort of left alternative and attacked that and demolished it, and the whole thing died. So that took the air from Wellstone McDermott. But that was really in 1991. That was the bill that almost every healthcare reform advocate pointed to as a solution.
Actually, it still exists. It's the same bill that's been introduced by Senator Sanders in the Senate. It's the only single-payer bill in the Senate.
Very good.
Yes.
Yes. Question. I work in healthcare also. I'm a SUNY downstate, and at the Disparity Center, and I work with a lot of community-based organizations. And I've participated in many meetings recently of a community-based organization trying to unpack what is represent specifically the medical home and the issue of the impact. And I really can see we meet the professionals, this group, and now very historical. I want to comment the first presentation, that I think that if the community of color need much more intervention to help understand the bill, to better make sure, because there's a trick here. If it failed, instead of people thinking of going universal, they can go back and saying the only thing that works is private health care, and because you share it failed. So it's an issue about if it's not universal, doesn't matter. So I think we need to find a place to intervene underground. People are meeting. There's many community meets every week trying to unpack this, and all they're getting is policy, but nobody helping them to construct strategy, to resolve it, to intervene in time, to pressure their legislators now to make it work, whatever have to work, and then plan later how we strategize in a deeper movement.
So I know that everybody up here is like, ooh, ooh, ooh. Could we please be talking and be working with you on this? So
we were talking.
We'll talk. Yes.
Okay.
I'm on your list.
I'm completely in favor of single payer. Let's say I'm petitioning for this New York bill, and I get talking with one of the people that stops, and this person is not a CEO, because I don't feel sorry for them, but this person is a low-level worker in the health insurance industry. What do I tell them about where can they plug in to the new system if we have single payer so that they will not become unemployed?
Well, I actually addressed that in a couple of ways. First of all, the insurance industry is now outsourcing a lot of those jobs to the Philippines, to all over third world countries. I've talked to them, these people who do prior authorizations, and I can barely understand them. You find out, well, that's because they're in another country. Those jobs are already being outsourced. That's a number one way to respond to that. But the second thing is that we're already seeing a job loss because employers are not hiring due to the cost of health insurance, or they're hiring someone half-time so they don't have to give the benefits.
Okay.
So we're already losing jobs, and what we can say to them is, yes, there will be some job loss. We acknowledge that, but at least you'll have health care. And in the HR 676, there's actually job retraining money.
Oh, good, okay, thank you.
Sorry, can I add quickly to that? And another, I think, very useful and common response to add to those very important points is that, and this is particularly, I think, relevant coming from physicians and nurses and other healthcare workers who are saying, yes, there will be some job loss, but we would much rather have people have jobs that to provide healthcare instead of deny it. Most of the folks who are working in insurance company pushing paper and denying folks, they're not happy. They know the lies that they use to make more profits for their companies. But it's their job, right? So they're pushing paper and they're denying healthcare. So I've heard many times physicians saying this to other people, saying, well, I'm a physician and I would much rather have more community health workers and, more doctors, more nurses, more team leaders and more social workers. People should be retrained to do various jobs that actually are productive and promote health instead of deny it.
Thank you.
And then person in the back.
I want to talk about a place far away, which is Louisiana, okay? And this law ends up producing all kinds of opportunities. Like Louisiana had its own state-run hospital system. ACA will finally kill it, okay? The system will no longer work with ACA. The African-American community thought that the state-run system and the indigent care system would be propped up by those community clinics that they were promised, okay? They gutted those out of the bill, and so now the state's hospitals are gone, okay, are leaving. So it's, in the ACA is going to create these little places where there's going to be a hook where you can get people to talk about future healthcare reforms.
I think that what he said is pretty much a point of view that has been held in the Latino community and in the community of color in general, and that is the whole thing of engagement. Engagement with PNHP and other groups that are progressive. But what's important is that there's a lot of problem in terms of what I think we were talking about it, the linguistics, in terms of the terminology. People sometimes, the whole of employment, that is a barrier. But my concern is that we should try to develop some sort of informational system nationally in terms of this situation. Because people believe that what he says, that one affordable care is passed, that's it. That's what's going to happen, and that's not what's going to happen. The concern is to make sure that we know something that is being used at this moment in Wall Street as the futures commodity, which is what is producing. General Petraeus just got hired on 42nd Street, running a poverty program. We had to sort of bring people into the reason. We're going to have this immigration law, so many people here. We had to develop some sort of national level way of communicating both the terminology and the history of the healthcare service in the United States, which in a sense has been progressive. I mean, we have a lot of people believing up to 90 and 100 and things like that. The right is we are 17 in the world. in terms of living, long-term standard living. But I think that's one thing that we should try to get is to try to see if you have some sort of overall picture of what is the healthcare, USA healthcare system. Because there's a lot of people, educated people, doctors. I was talking to you up in Vermont. They have no idea of what is that they're doing. Some of them even commit suicide after 3 years of being in medical school. But we have to deal with that kind of issue, otherwise we're lost.
Yes.
In addition to calling Mr. Silver.
Can you speak up?
In addition to calling Mr. Silver, which I will
Right.
do, in addition to contributing some money to the healthcare, what else can I do? What can I do?
Oh, wow. Well, first, yeah,
Gosh.
that's fantastic. First of all, do we have your information?
Yes.
And so secondly, we are, as Amy was saying, and she was giving details about how she's organizing at her medical school and with other medical schools. So there are a number of things we want to find out. What district you live in, right? And then we want to find out who else is in your district, what organizations, what other single-payer activists, and whether your legislator is already a co-sponsor. If not, obviously we'll work on them with your help. If so, we want to increase their engagement, like what Amy was saying. Do a town hall. Now the town hall has a whole bunch of goals. Like one is to really force the legislator to be public about his or her support of this bill. And we do often use as kind of a Trojan horse, we use the Affordable Care Act as a Trojan horse to talk about single payer. We see, because people want to know what's happening to them. How does this affect me? So in fact, the forum, what was the title of the town hall if you agree with this?
It was on the Affordable Care Act and single payer. Yeah. How will this affect you essentially? How will it change?
So we use that to first say, this is what the Affordable Care Act does. We're not there to trash it. We're there to say these are the facts. And then we say, well, let's go beyond it. And here's the New York Health Bill. So the more constituents are educated in that district, the more that legislator knows that, oh, this is not just some fringe issue that I just put my name on and never have to think about again. So we should talk, and I'd love to find out if your legislator is already on board.